Let's cover glaucoma. Now in this video we're going to cover the basics of glaucoma, one of the largest diagnoses and most important things we need to know in the eye clinic. And we're going to go over a couple things, including the aqueous pathway, the difference between open and closed angle glaucoma, some pressure and exam techniques unique to this field, and some of the medical and surgical treatment options in these patients. So let's just go ahead and get started. The first question is, what is glaucoma? Now, there are a lot of theories as to what glaucoma is, and unfortunately there's not really a straightforward answer. Some of the theories think that maybe there's damage from increased intraocular pressure. Basically, this pressure is damaging the eye in some way. Some people postulate that maybe there's stretching damage from stretching the walls of the eye and therefore the tissues involved. Maybe there's vascular compromise. The increased pressure decreases the vascular supply to the optic nerve. And other people think maybe there's some type of neurotransmitter involved with this process. But what it comes down to, probably the best answer for what is glaucoma is death of the optic nerve. Now, the optic nerve comes into the back of the eye and then travels along the surface of the retina and is the important pathway for the signal from the photoreceptors back to the brain. And with glaucoma, for whatever reason, the ganglion nerves die off, which leads to decreased vision and morbidity. Now, to really discuss the different types of glaucoma, we need to understand the aqueous pathway because this is crucial to the diagnosis. Now, aqueous is the supporting nutrition of the eye and supplies nutrition to the avascular structures of the eye, such as the lens. If the lens doesn't have a blood supply, it gets nutrition from the aqueous. Maybe the central cornea, there's no blood vessels running into the middle of the eye right here. So the aqueous is very important, plus it creates the anterior chamber. So the aqueous is produced here in the ciliary body, back behind the iris. It then floats forward over the lens, back here in the posterior chamber, comes up through the pupil, and spreads out throughout the anterior chamber, and then goes into the angle. And when we talk about angle, what we mean is the angle formed by the cornea and the iris. This is an iridocorneal angle, which has some important structures, including the trabecular meshwork, which is like a filter, and the canal of Schlemm, where the aqueous drains back into the circulation. Now, when we talk about open versus closed angle, that has everything to do with this angle here. With open angle glaucoma, which is the majority of our patients, we have a dysfunction of the trabecular meshwork. Something happens here. We're not entirely sure what, but for some reason aqueous doesn't seem to drain very well, and you have an increase in pressure. That's different than closed angle glaucoma, which is an acute emergency, where the angle closes off because everything shoves forward and aqueous has no access to the outlet entirely, so the pressure goes up very quickly and very high and can quickly lead to permanent problems. But let's start with open angle glaucoma, because this is what we see most in our clinics, and you really ought to know a lot about it. This is the kind of like essential hypertension. This is something we see a lot, and the majority of our glaucoma patients have this. Now, there are a lot of risk factors for having open angle glaucoma, and I'm going to go through some of these in the next few slides, but let's go ahead and list them. High intraocular pressure, that's obvious. If you have a patient with high pressure, then you think about glaucoma. Increasing age, family history, race, suspicious optic nerves in the back of the eye, and people with thin corneas are also at higher risk. But let's go over some of these. Now, when we're following our patients with glaucoma, we really measure and follow three findings, which of those risk factors are probably the most important, and that's elevated pressure, optic disc changes, and visual field changes. So let's go through those as well. So when we check pressure, we can do it one of two ways. We can do it through Applanation, which is, I'll show you that in a second, or Tono-Pen. So Applanation is basically that little blue light. What this thing is a little device that presses on the eye. We actually shove this onto the surface of the cornea, and it measures how much force it takes to flatten the cornea a certain area. So there's a little area here, and it flattens the cornea, and there's a little scale down here in the bottom of this device that we measure how much force it took to flatten it. And it gives you an idea of how high the turgor is in the eye. When we do it, this is what we see. We turn the blue light on and we put fluorescein in the eye, and we're looking at the eye. This is the upper lid and the lower lid somewhere down here in the shadows, and what we see is a circle. Now we put a prism into this little device here, and what this prism does is it allows us to figure out exactly how much area of cornea we flatten, and the goal here is for this prism to form a perfect circle with the inside edges of the top half of the circle and the inside edge here just touching, kind of like this. And when they're just touching, then we know we have the exact area that we're trying to flatten, and then we look at our pressure measurements and see how much pressure it took, and those things are calibrated for that to work. Now the other way we can do it is with a Tono-Pen device, which is very similar. You tap on the eye with this thing, and it mechanically tells us what the pressure is inside the eye. The next thing we want to look at is the optic nerve changes. Now with glaucoma, like I said, we have death of the ganglion nerves that form the optic nerve. When we look in the eye, we look at the cup and the disc. Now the disc is just the optic nerve, and that's just a slightly light-colored thing that we looked at in our retina video. But the cup is a little divot right in the middle of this thing, which kind of corresponds to where everything kind of dives down, because these nerves are diving down, and there should be a little divot there, a little cup. Now, if you have death of some of your optic nerve, then you're going to have less ganglion nerves running through your optic disc, and your cup gets bigger, and it gets bigger like that. So healthy, and then as there's less stuff running through there, you get a larger cup. And so we look at these findings in the back of the eye. Here's an example of a small cup and a larger cup. This picture on the left is my eye, and we really need stereo 3D photographs to get an idea of depth here, but you can kind of get an idea that there's a small cup right here. And so we look at the cup to the disc ratio, and I'd say it's about 0.2 or 20% of the size of this thing. This is only about 20%. Compare that to this eye, which is actually a pretty healthy looking eye, but the cup is much bigger. And so here it's more like 50%. So we'd call that cup to disc ratio, the cup to the disc, about 0.5. Now, people with glaucoma, they lose a lot of the nerves going through this thing, and so they get very large cups, and they tend to lose some of the nerves, especially in the superior and the inferior portion of the nerve. And most patients follow the ISNT rule, which just says that when you look at the neuroretinal rim thickness, it usually follows the ISNT rule from increasing to decreasing thickness, meaning that I is the inferior is usually the thickest, and T, the temporal, is usually the thinnest. Now with glaucoma patients, a lot of times their I and their S, the inferior and superior, get knocked out more, and so they go against the ISNT rule, which is a nice finding. Well, it's not nice, but it's a finding. The other thing we watch for in these patients is visual field, because these patients lose peripheral vision, or more accurately, they lose very stereotypical scotomas of blindness. And so this is a Goldman machine, one of the devices we use to sort of map out a patient's vision, their visual acuity, and basically we shine different lights of different brightnesses and size, and we can draw out what they're seeing and follow the progression that way. But more often we use something called the Humphrey Visual Field, which is an automated computer-controlled device that does something very similar, which is much easier and standardized between multiple clinics. Now, the importance of corneal thickness. Now, some studies somewhat recently have shown that people with very thin corneas that are higher risk for having open-angle glaucoma, and also the corneal thickness will affect your pressure measurement. Now, if you remember, what we did before was we measured the pressure by basically pushing on the eye with a little measuring device. But if someone has a very thin or thick cornea, you can get various results. Now, this is a pachymeter, which is a device that just uses ultrasound to measure how thick the cornea is. Now, I've had LASIK, so my cornea is a little bit thinner than average. But here's a good example of what I'm talking about. Now, you can imagine a patient has a very thick cornea, and you can think of them having a thick rubber. So when we push on the eye with that little device, it's kind of like kicking the tire to get an idea of how much the air pressure is inside. Now, someone with a very thick cornea, or a truck tire cornea, has a very thick rubber, and so when you push on it, it seems pretty hard, really no matter how much air is pumped into this tire. compare that to, say, a bike tire, which is very thin rubber. When you push on a bike tire, it seems much softer. Even though the bike tire and the car tire are essentially pumped up to about the same PSI, usually about 40 PSI. So when you look at a patient, you have to decide, do they have truck tire eyes or do they have bike tire eyes? If they have, and that's going to affect how you calibrate your measurement of their pressure. Closed angle glaucoma. This is the other type of glaucoma, much more rare. I haven't seen as many of them, especially in this country, but because it can lead to very bad outcomes if it's not treated properly, it's something that we need to be able to recognize and treat right away. People who are at risk have shallow chambers and small eyes, big cataracts, dilation, but I'm going to go through these one at a time. It'll make more sense. So let's go over the mechanism again. With closed angle glaucoma, what happens is that aqueous is produced back here in the ciliary body as usual, and it comes forward. However, for some reason, they get pupillary block. The aqueous is not able to get around the pupillary margin into the anterior chamber. And when that happens, a pressure gradient builds up, where the pressure back here is higher than the pressure in the anterior chamber. And when that happens, everything pushes forward and rotates up. Now, I didn't draw this picture real well, but it pretty much shows what I'm talking about. When things get pushed forward, the drainage angle gets closed off entirely, and you get a positive feedback loop. And the pressure continues to build, continues to not be able to drain out. Pressure gets very high and can kill off the optic nerve very quickly. Now, people with shallow chambers are at a higher risk for this thing occurring. And when we look at chamber depth, you can actually gauge a patient's approximate chamber depth just using the slit lamp exam. For example, this is an eye I'm looking at with a slit beam right here shooting into the eye from left to right, and here it is hitting the cornea, and here's the same light source hitting the iris. And you can see that there's a big space here. This is all filled with aqueous, and so this is a pretty deep chamber. Now let's compare another patient. These two pictures come from the same patient. He's got a corneal ulcer which perforates in the second picture, but in the first picture you can see that the chamber, the distance between the cornea and the iris, is pretty big. But over here the distance is very small. And that's because he had a perforated cornea, all the aqueous leaked out of the front of the eye, and the chamber flattened. Now, when you're trying to evaluate a shallow chamber, you can do quite a bit with just a pen light, because if you shine a pen light sideways across an eye, the entire iris ought to pretty much illuminate. However, in a shallow chamber, you can get a little bit of a shadow over here, kind of like a little volcano, and that just gives you an idea that maybe they have occludable angles. And here is not the greatest video of it, but basically I'm holding a pen light sideways, and you can see a little shadow over here. Really, the whole iris ought to light up, but it's a little bit dark on this half of the iris, kind of like shooting a light across a volcano, and you get a little shadow on the back side of the volcano, and that's a somewhat shallow chamber. Now, you may see findings like this, but really the most important thing is not so much that their chamber is somewhat shallow, but whether the angle is shallow and a setup for closing off and giving them a closed angle glaucoma attack. Here's the problem though. You can't see the drainage angle. You just can't look at the trabecular meshwork and Schlemm's canal and all that stuff. You just can't look at it. And the reason being is that the angle of the eye is such that the water/cornea air interface creates a reflection where light coming off of it hits here, and because of Snell's law, it bounces off, just like how fiber optic cables work. The light beam passes along the cable, or how if you've ever been scuba diving or snorkeling, and if you look straight up you can see the sky, but if you look slightly off to the side you get sort of a mirror image. And so we can't look into the eye to see this thing directly because of this cornea air interface. This change in density just won't let us do it. To get over this total internal reflection, we use something called a gonio mirror, which is basically a glass mirror that we stick onto the eye, and that breaks that interface and allows light to travel out. And then we have little mirrors here that lets the light travel forward so we can actually look into this angle. And to do that we use a little mirror like this. That's the part that goes on the eye. And looking straight ahead, you can see that there's actually 4 mirrors, 1, 2, 3, 4 right here. That lets us look into all 4 quadrants of the trabecular meshwork. Now this is a video showing what it looks like to look through one of those mirrors. This is the middle of the eye, and this is a mirror kind of looking across to the other side of the eye. So here is the pupil, here is the iris, and this over here is the inside of the cornea. And so what you can see here is a little line right between the iris and the cornea, which is where the trabecular meshwork is, and it's not easy to see. And gonioscopy takes a while to get good at it, and sometimes these are difficult to see. But in this case, you can see that the angle is pretty much open. If you couldn't see the trabecular meshwork because the iris was bowed forward, then you'd know maybe they were set up for closed-angle glaucoma. Another thing that might cause closed-angle glaucoma is crowding from dilation. Now, when the iris is constricted, the angle is pretty much open. However, if you dilate a patient, then their angle gets somewhat crowded and could be a setup for glaucoma or a closed-angle glaucoma. And many patients who come in with a closed-angle attack say it occurred, say, in a dark room. When you look at these patients, their eye is red, they're in a lot of pain, usually nausea, and their cornea is steamy. It's all clouded with fluid because the pressure is so high inside the eye. And you can see here that everything's cloudy, very hard to see in, and you can imagine that it's hard to use gonioscopy to look at their angles when their eye is this cloudy. You just don't have a good access in. And patients will complain of halos, and that's what you get when you have corneal swelling. Now, you know, normally the cornea has an endothelial pump on the inside that continuously pumps water out of the cornea back into the eye, but if the pressure's high enough with these acute attacks, then water gets pushed into the cornea, and that's when you get that corneal edema. Now, treatments for glaucoma are either medical or surgical. With medical therapy, this is what we use mostly for our open-angle glaucomas. The goal really is to either decrease aqueous production or to increase the outflow. So if you think of the eye as a sink, you either want to turn the faucet down or you want to add some Drano to get the pipes flowing better. And so to decrease production, we'll use beta blockers, carbonic anhydrase inhibitors, and to increase outflow, we'll use prostaglandin analogs, alpha agonists, and a couple of other medications. I don't want to go into that too much because that can be confusing at this point. For a patient with closed-angle glaucoma, really what we want to do is we want to break the pressure differential, because there's very high pressure back here and very low pressure here. And to break that differential, we can use a laser and actually pop a hole through the iris and let the pressure equalize between the front and the back, and everything lies back down into place, and you break the attack. Now, patients may have intractable glaucoma, or glaucoma just is not being treated well with just eye drops. And we can do a couple of surgical treatments. One of them is a trabeculectomy, and basically what this does is we create an alternate drain. So if you think of the eye as a sink, we add another pipe to the sink to let things drain out. And so what we can do is actually create a hole through the side of the eye and let fluid drain really from the anterior chamber through the eye. But we don't want it draining out to the environment. We want it draining underneath the conjunctival tissue. And so you create a little blister here. Here's a video of that. What we have here is a patient. If you look real close here, there's a little triangle. And what we've done here is we've created a triangular flap and then dug a hole with a knife, basically, into the anterior chamber of the eye. And fluid drains out of the eye underneath this flap. Now, we don't want this fluid draining down the front of the eye and down the cheek, and so what we do is we cover it all up with conjunctival tissue, and so it creates kind of like a blister. And this whole little light color thing here is a blister of fluid that slowly percolates back into the system. And you can see the blister because it looks kind of clear here. That's the clear conjunctival tissue, and then there's the flap. And if you look at this flap closely, you can see here's the triangular flap, and there's a couple of sutures here that we tied down just to keep the flap from working too well. And then if the flap's not draining as well as you would like, you can use a laser to break these sutures and get this thing flowing even better. Another option is to put a tube shunt in, and that's basically putting a silicone tube into the eye, which drains the fluid further back, further near the equator of the eye. And you can see that in this video, that there's a silicone tube here in the anterior chamber of the eye that drains fluid back around to the side of the eye. And then there's always treatments with lasers that can zap the trabecular meshwork and scar it down, which has a tendency to open it up and let fluid drain a little bit easier. Now there's other types of glaucoma. For example, if you got a patient that has had a real bad diabetic retinopathy or a central retinal vein occlusion, they may have a bunch of ischemic retina in the back of their eye that's producing VEGF, and that VEGF can actually percolate around the lens into the front part of the eye, and you can get neovascularization on the iris, and that's what all these little vessels are here. If these vessels get into the trabecular meshwork, it's like roots getting into your plumbing. It clogs it up, and you get a real bad glaucoma. It's very hard to treat. Here's another interesting syndrome that we see somewhat commonly, Pseudoexfoliation Syndrome. These patients get a basement membrane type material that forms on the lens right here. That's what this little rough of white stuff here is. And as the iris dilates and contracts, this rough stuff kicks off pigment, which that pigment goes and clogs up the trabecular meshwork, and you get high pressures. I think that's the end for this video, but as always, you can download the PDF file for this video from ophthalbook.com, and you'll find other videos on the website as well. If you are going to read the chapters, I recommend actually downloading the PDF version and printing it, because the layout looks much better and correlates directly with this video. Thanks for watching.